studies that we're also doing here.
Yes.
So, yeah.
Right. Which is okay for these guys to hear.
Okay, ladies and germs, we're ready to begin our March Consortium meeting, which we're all excited about. We have some great speakers, even remote speakers. We're very high tech at this meeting here.
It won't be a very long meeting.
We're going to run through these subjects hopefully quite quickly. And is Palm Springs
Leave
ready?
time for questions, you know.
Yeah.
Palm Springs is going to sign on at 10:30.
Okay, so then we'll
And what we're learning is
first.
there's similar studies. We're going to talk about research today.
You go first?
Yeah,
I'm going first, I think.
yeah. But
So-
some are open here in both places, yeah.
So the topic of studies and research and all, the two dominated some of these meetings. And so Marvin's back here. He is, of course, with the ABRC, UCSD, and is in charge, oversees the recruitment. or-
Yeah.
the-
Community outreach and recruitment.
Yes. Computer, what is your actual title?
Community engagement manager.
Community engagement manager. Okay. So
The ABRC.
And he won a Red Trucks Award for the Red Dress Party, I thought.
We got awarded last year. Yeah.
yeah, he won a red truck award. Is that what you said? Anyway, without further ado, Marvin, take the podium.
I've seen this guy.
But don't
Cool.
take the laptop.
Yeah. All right. Hi, good morning, everyone. Thanks for welcoming me back. My name is Marvin Hanashiro, and I'm the Community Engagement Manager for the Antiviral Research Center at UCSD. So I was asked today, to just kind of bring up a couple of studies that we've talked about in the past, but really focus on the new programs that we have coming soon. So first thing I wanted to mention is most people know, but our offices are located in Hillcrest. They're not too far away. That's what our building looks like. And we are just north of the UCSD Hillcrest Medical Center, the tall building. So we're also in the same building as the HNRP. So a lot of times people get us confused, but we're two different research groups. We both focus on HIV research, but as most people know, the HNRP really focuses on how HIV affects the brain and memory and concentration. And the AVRC mostly focuses on drug trials. So that's what I'm going to be talking about.
And are all these studies that you're going to talk about for people with HIV?
Yes, although we do have a few studies that are looking for HIV prevention, and so it's status neutral. And then we have a couple other studies for medical diagnostics. It doesn't matter about HIV status.
Okay.
So, cool.
Because in these rehabs and places like that, in these, what do we call them, halfway houses? We don't call them that anymore. Sober living homes.
Right.
There's a combination of men and women, and stepping out is.
Oh, definitely.
5%.
And we work with them a lot too.
Okay, good.
Yeah,
I'm
which is
just
nice.
saying, good way to
Mm-hmm.
Marvin.
Marvin.
So,
I'm happy to help in your efforts.
yeah. So these are the research areas that we have. So we focus on COVID, HIV, a new area is medical diagnostics, and then sexual health in general. So we currently don't have, yes.
What is medical diagnosis according to that?
So what, like testing devices. So that's one of the studies I'm going to mention later.
Can you all write down your questions? Because otherwise I don't think it's going to get too simple.
It's okay. No, that's fine. That's a good,
Just between you and I.
that's a point of clarification. I get it. I will say right now, we don't have any COVID trials, but for example, when COVID first came out, our research center actually did the Janssen vaccine trials as well as the AstraZeneca vaccines. So those were two of the things. And we did the treatment trial that got Paxlovid approved. So we were one of the sites for that. So we currently don't have any COVID trials, but there might be we're working on a contract with a new COVID vaccine company to see for alternative options, a different type of technology than like the mRNAs that like Moderna uses and Pfizer uses. So this is coming down the line, but we don't have anything open. All right, so, okay, first study. So I know we wanted to wait, but the first study, this is called A5403, which is Get It Right. And we're really excited about this trial because it's really focused on trying to find It's for trans women, as well as people who identify as feminine or trans feminine, but are sex assigned male at birth, and really trying to discern treatment with feminizing hormone therapy. So there has not been a study up to this point to really show what the right dosage of like estradiol, which is a feminizing hormone, mixed with what type of HIV treatment. So the purpose of this study is to see if we'll assess if hormone levels change based on the type of HIV medication that someone's taking, and as well as just making sure what is the best combo. So people are going to be in different combinations, and what happens is when people begin, they have to not have been on any female hormone therapy, but they can have restarted. So they can have past history, but when they start, they have to be it has to be out of their system. And what happens is they start on one dosage, and it slowly increases over time, over 48 weeks. And then they're going to during the course of the trial, then we'll determine to make sure that the hormone levels aren't affected, that HIV drug levels are still high in the system. So whatever, and this is the first study that's really going to show what combinations are probably best, or if there's really no changes. We don't really know. So we're excited about that. So that's coming. We're actually, I think, starting this month or next month for this trial. So anyone over the age of 18, they have to be living with HIV, also on certain regimens, and identify as a trans woman or female or trans feminine person, male with male sex assigned at birth, and then the desire to initiate or restart their feminizing hormone therapy. Okay.
What's the advantage to the person who's in the study?
So
why would I want to? I mean, obviously I wouldn't. But
yeah, no. So I mean, a lot of these.
I'm trying to quit.
Yeah, for some of these trials too, it's access. So everyone's going to be receiving estradiol, right? But I know that can also be given to your physician as well. So really, though, it's just going to be people whose desire to really show that these things can work together. I know there's always a big fear when I talk to people that people really want to focus on their female hormones, right? And that HIV treatment becomes secondary. And so we want to show people that they don't have to compete. And this trial hopefully will prove that, but we don't know, not for certain. So we're just really hoping that people are willing to participate. So for the most part, I understand that a lot of people aren't going to stop their treatment. So we're really looking for people who are probably just starting for the first time and that are willing to do this while they're getting on their hormones. So that happens normally, as far as I understand, in medical care. So in the dosing for female hormone therapy, that they start at a low level and they titrate up. So this study will mirror that, so that they're not going to be taken away from any other type of the standard of care when it comes to receiving female hormones. So hopefully this is going to be like going in line with someone's normal trajectory, but they're just doing it in the context of a study. So one other study we're doing, which is the Gilead trial, it's called Artistry 1 and 2. So this one's a pretty easy study to participate in. Basically, we're just trying to compare taking oral Biktarvy and lenacapavir pill versus someone on a complex ART regimen. So they just want to show whether or not that the Biktarvy lenacapavir pill is not inferior to someone's current treatment. So as far as what a complex ART regimen is considered in this trial is anyone that's containing a boosted protease inhibitor or an NRTI plus one other agent, or they're taking 2 or more pills a day, requiring dosing more than once daily. So that's what's considered complex. So they want to try to simplify someone's treatment, and they believe that this combo pill won't be inferior to someone's current regimen.
I hope not, because I'm on it.
Yeah. So Artistry 2 is basically a similar study, but it's anyone that's currently taking Biktarvy, and they want to show whether or not switching to the oral bictegravir lenacapavir is also not inferior. So I will say for both studies, they're randomized and it's open. It's an open label, meaning you'll know whether or not you're randomized to either staying on your current regimen or if you're going to be asked to switch to the bictegravir lenacapavir. And so as far as I know, the ratio is 2-to-1. So two people will get switched to the bictegravir, lenacapavir arm, and then 1-to-1 will stay on their current regimen. So, and you'll know which one you've been randomized to. So this what? Oh yeah.
Oh yeah, before we go to that. So a possible benefit of participating in this is that someone can take fewer pills and have, hopefully because of that, fewer side effects.
Right.
And there's at least, the first patient that it was kind of done in is getting the injectable. But this is oral.
This is oral.
Lenacapavir. So the advantage of lenacapavir is, as far as I know, is the best drug in the setting of resistance. It will overcome just about anything. You have to use it with other drugs. So they're going to figure out if you can use this really powerful lenacapavir with just one other drug, bictegravir, which is pretty powerful also, and eliminate many other pills. So what did you go from? It was just horrible because you were getting 2 protease inhibitors. You were like this ridiculous 2000 regimen. Yeah.
For many years, I'm fine.
Yeah, but each medicine had more than 1 pill. I don't know. You were taking lots and lots of tablets. But 5 medicines, right? 5 different ones, and you went down to how many? 1 tablet plus the lenacapavir injection?
Yeah.
Right, this is just
2 tablets.
This is the extreme example. John's letting me talk about him because that is extreme, and it worked, right? The injectable lenacapavir. So it's conceptually the same, and I'm okay talking about it that way. And then you go talk about it. You make sure to always talk to your primary care doctor before you go enroll in a study, and stop the medicines that your primary care doctor is prescribing.
I'm the San Diego expert.
And that study has a lot. It is a useful study, and they're going to enroll people safely. So I think that when I look at it, the risk is pretty low.
Right.
You can only get benefit that it's going to be better tolerated. And what is the exact dosing? You take, it's not fixed dose because you have a slash. It's 2 different tablets.
I can't remember off the top of my head,
Okay,
but yeah.
so and then each one is daily?
Yeah.
Okay.
Yeah. I did mention this study in the past, but I'm going to go through it one more time because I was.
Did that generate any questions? You guys understood what I was trying to comment on? Okay, sorry. Thanks. Okay.
So we have a trial coming up. It's been postponed a little bit because there's still some negotiations with the FDA to make sure that we're doing this as safe as possible, because it is a pilot phase 1 trial. So there are definite risks involved in doing the trial, but there's a lot of potential promise for some exciting new therapies. So it's a CMV HIV CAR T-cell trial, and I put HIV cure in parentheses, and I use that term loosely because this trial is looking to see if this type of therapy could potentially be an HIV cure. But I will say that because it's a pilot study and it's phase 1, the focus of this trial is about safety and feasibility. So we can't promise that anyone participating in this phase 1 version of the trial will be cured. But if this works, it'll go to a phase 2, and the phase 2 is really going to then be focused on efficacy and then finding the right dosage for the actual effective therapy. So let me get into it. So as I mentioned, the primary goal is to assess the safety and feasibility of administering your own modified T cells. So to back up a little bit, from what I understand, CAR T cell therapy has successfully been used to treat a lot of blood cancers. So what they do is they take your T cells, they extract them from your body, and they genetically modify them to attack a specific virus or whatnot, right? So what we're doing in this trial is we're using the same type of therapy, but we're extracting CMV or T cells that are specific to attacking CMV. And we know that almost everyone, regardless of HIV status, has CMV in their body, but your body's able to treat or handle CMV on its own. So what we're doing is we would extract all this or as much CMV specific T cells as we can, and then we also genetically modify it then to also recognize HIV at the same time, so that it goes for both, right? And by doing that then, and then after that's done, those genetically modified T cells are going to be put back in your body, and they're your own T cells. It's just modified. And then you'll be given a CMV vaccine to activate that even more so that it's like super boosted, right? And what it's going to do then is hopefully, it's what theoretically it's going to hopefully eliminate HIV throughout every part, all the parts of the body. So that's the goal, right?
Sign me up.
Yeah. Well, so,
But if it doesn't work, you'll be blind.
yeah, no.
Yeah.
Well, I
The
did.
important part of what he said is this is a phase 1,
Right.
so it offers no benefit. Like the participants really are only benefiting science.
Right.
That's where this is.
Yeah.
So it has to be somebody who, it's not such a long study, willing to take a small risk for a short amount of time and then go back on their method only
Right.
to help science.
Right.
And mostly we want to talk about it to give hope, right?
Yes.
Like the researchers are working very hard on, the main reason why people with HIV live longer is because of medicines and all the research that went into it, and then all the other holistic stuff we're talking about,
Mhm.
exercise. But it's really number one is really the medicines, and so this is to learn today.
Right. No, definitely.
Mostly to learn.
But my understanding of this one,
Yeah. Sorry.
Dr. Smith,
Mhm.
David Smith. described
Right,
it.
this is just repeat, just because people didn't really understand what he said, and there were like quite a few comments about, we just repeat it again.
But you say it's no small risk, and I understand that they don't know the risk because
Well-
of re-injecting the CMV.
In terms of time, right, the shorter amount of time you're off meds, the
Oh.
less the risk,
That
I
kind
guess
of
is right,
risk, right.
right?
Yeah.
The
But
CMV
you're
is
right,
something- it could
there's
be
all these other
attacked.
like unknown risks, really, this is
Right,
a vaccine,
right.
you really have to be, willing to be a guinea pig, I don't know any other way.
Right.
Yeah. You know,
It's a
and
phase 1 study, but it's really just to inform the community
right.
about what is going on at least
But-
this is after the poor animals that have been experimented on.
I will mention, I mean-
What it takes to get, I know, which is a whole other spiritual point to touch on. Wanda almost like
Just slightly off.
Wanda Rocket. We'll call her Wanda Rocket. She didn't take off yet. Somebody in the corner though, John.
It says no age diagnosis, so that limits your
Yeah.
people.
So there's a few things. Because it's a phase 1 trial, the way that Dr. Smith explained it to me is we need to find people with the healthiest types of T cells in this phase 1. So currently, in future phases, that exclusion might be eliminated, will most likely be eliminated. But they need to find the people with the best, like healthiest T cells they can, and to show that this is even feasible, that it's even any type of effective, right? So that's why we're looking for anyone over the age of 18 that's undetectable, which is what most studies require. They do have to have a T cell count and maintain of 450 or higher with no previous AIDS diagnosis. They would be having to be willing to temporarily interrupt their HIV treatment for 4 days to do the leukapheresis, which is basically the extraction of the T cells from your body. And so, going along with that, they can't currently be taking an NRTI because I guess that actually interferes with the leukapheresis process. So I have spoken to some people, and you can switch. So if you meet the other criteria, but you're on an NRTI, but you're eligible to switch to a different medication, you could do that before enrolling in the trial. So there's ways to go to adjust.
Yeah, probably a couple things to understand. CAR T cell therapy is not new.
Mhm.
As Marvin mentioned, it's been used in cancer therapy for quite a while. You do have to be aware that the leukapheresis stages go up to City of Hope, come back, you're done. Once they administer the modified T cells, you have to stay up there for 2 weeks.
2 weeks.
With the helper, with the.
Right.
Because there is the potential for interleukin storm, I think.
Yeah, cytokine. So basically, your immune system's overactivated and it kind of attacks itself. So that is a risk that is associated with CAR T cell therapy in general, right?
Right, and you have a chance of almost done.
Yeah.
Right.
So what's the
But
percentage?
this is like
of the risk?
hardcore research.
They've gotten very good at
Just
managing
share.
that.
Mhm. And I guess that the city. So we're partnering with the City of Hope because they're experts in this type of therapy, and so they have also medications that can be administered at the hospital if there are signs that these side effects are happening. So that's why they require people to be there for 2 weeks after.
Yeah.
And you have a caregiver with you so that you can immediately or someone can be a medical professional could be notified so that they could correct whatever side effects could occur. So, and it's a good question about what percentage. Like, we don't know, because in cancer, they have some of those numbers, but this has not been, there's only 4 trials, in my understanding, in the world that are trying to use CAR T-cell therapy for HIV. But each one of the CAR T-cell therapies are focusing on a different aspect. And we're the only one using the CMV T-cell to also learn how to attack HIV. Whereas the other CAR T-cell therapies are using a different vector or different entryway, I should say.
Different door.
Different door, perfect. Yeah. Cool. So as far as HIV prevention trials go, we just completed one arm where we're using long-acting lenacapavir to prevent HIV. It's a PrEP, right? So Purpose 2 was a trial that only enrolled cisgender men and trans women to do the trial, but that arm is closed now. So now the company has opened up Purpose 3 and 4, and Purpose 3 is only for cisgender women to see whether or not if this twice a year injection medication is effective for preventing HIV. I will say that, and for this trial, people are randomized to either receiving Truvada, which has already been shown to be an effective treatment for HIV, or prevention, I should say, as an oral pill, or randomized to receiving the injection. So that's the caveat. But yeah, this trial is only for cis women that are sexually active, to show if this is going to be another option.
How many trials are open just for women?
This one, so
just women.
Yeah, so I mean, we do have the trans women. We have the hormone therapy trial, which is for trans women, and then this is the only one. This one is the one only focused on cis women for HIV prevention, I should say. And then Purpose 4 is the same trial, but the different arm. So we're looking at seeing whether or not this is an effective treatment for people who inject drugs. So there's no gender requirement, anything. It's anyone that is an active injection drug user, to see whether or not this also works to prevent HIV. I think this might be the last one. So this is the medical diagnostics area that we're starting to go into. So we're just looking to validate whether or not there's a point of care instrument, like a lab analyzer that's in the medical office that can reproduce lab results within like 30 minutes. So we're trying to see if this actually works. So anyone that's over the age of 18 and that's recently received a recent lab result indicating signs of diabetes, liver, heart, kidney, thyroid, or blood disease. So they have to have like elevated values, and that we can, first of all, give to our normal lab, and then validate that against this new device, to see whether or not it's how they correlate, or if it's even picking up the levels. But what's exciting about it is because then, this type of instrument can be used in a doctor's office versus blood tests having to be sent out to a lab, especially for like resource limited areas, right? Low income areas, resource limited. So it could be exciting, but this is a very simple trial, and it's a one-time visit, blood draw, and you get paid $40.
How high do the levels have to be above the norm?
So that all varies, and it's like a huge list.
Okay.
Yeah, but as long as if they're elevated, then most likely there has to be a certain number, like you said. But I don't know every single one off the top of my head.
And do they go to Hillcrest?
They do.
Everything goes to Hillcrest.
So it's all of this, except for the City of Hope, which we pair with. Parking. We have our own parking that's free for participants. So I'll mention compensation, which goes into kind of a little bit of both. So all of our research studies compensate people with cash for completing study visits. And the compensation amounts vary, though, depending on which is why I didn't put it in each slide, depending on the time and risk involved in the study visit or procedure.
But we don't care.
Yeah. Well, I mean, it helps, right? It's nice. But basically, like, just to give an example, you get paid a certain amount for a blood draw, but then for something that's a little bit more invasive, like a lumbar puncture or a leukapheresis, then you get compensated more money, for example. But I do want to mention that transportation can be arranged, and that's extra for people that are having difficulty with transportation, we usually can schedule a ride share or a taxi for people. That's it.
Okay, thank you very much. And where do we sign up?
I have forms if you want to give me your contact info, and I can reach out to you this coming week.
That's
So I'll stay.
that's one contact.
Oh, okay, perfect. Yeah, I'll stay for the whole meeting. So.
Do you have any way of like,
We both are engaged, yeah.
Engaged?
Engaged with managers. Do you have rings?
Oh, I don't. I have nice nails though.
Rocky
Yeah.
That's inviting,
Yeah.
not engaging.
Yeah.
it strikes me that, like, for example, Dr. Caperna has a profile of patients that he would know best who would qualify, but that's a lot of work for him. Is there any kind of system where?
Well, I mean, Dr. Caperna is actually amazing at referring people to us at times. You know?
You're right. You got to think about it. And I really put some effort into talking to every HIV patient that showed up about the Palm Springs site because they had never heard about it.
Right.
And I realized this was taking like 5 or 10 minutes extra an appointment.
Right.
To show them the list of like 6 studies they used to have open and describe who to call. They'll pay for transportation out there. And it's the same kind of thing when I bring up UCSD studies. I've got to really slow down and do it. So you're right.
And I'll make sure too, like I brought a bunch of just general flyers, not specific to any one study, just with their contact info and website, because I update that website as often as I can with the new trials coming up. So I'll make sure they have it, because I know it's a lot of work for physicians and nurses and whatnot to have to add that on to their visit and talk about. So
Most of them don't.
Right, I want to make it easy as possible to, if anything, like, here, if you're open to research, take this flyer and like call.
And that's what part of today is, right? I mean, UCSD has Community Action Board, which is part of the research center, which is part of it, I think, is also to disseminate information, which is what today is. You guys will go talk to people. And it's other ways to hear about studies other than the doctor's office, because it doesn't, you're right. Well, the next person's going to talk about Palm Springs studies, I think. Did you see her sign on yet? No, you can see him sign on, yeah.
Here you go.
Hi, Dr. Caperna. I'm here.
Oh, here.
Oh, jeez.
Hi, Dr. Morcos.
Hi, thanks for having me on.
Thanks. So UCSD just talked about a few studies, actually. And one of them was the Gilead study with lenacapavir and bictegravir.
Mm-hmm.
And you have that same study, right?
We do, and we have a number of really exciting trials in addition to that one.
Right.
And I can talk about what they are. And
yeah, that'd be good, because I think that they understand the value of the study. Maybe you could say quick, be short on that one. And how many pills is it a day?
Yeah, sure. I can. Yes. So let me cover kind of like the main studies that we are enrolling for and things that are coming up. So we do have that study of bictegravir, lenacapavir for patients who are currently on complex regimens, and they'd be switched over to a once a day combination of those 2 medications. But they're also running another trial that we're doing for patients who are on Biktarvy, to be switched over to bictegravir, lenacapavir. And we just got approved for a study for patients who are currently on Biktarvy and to switch them over to an oral once a week regimen. So instead of taking a pill every day, taking your Biktarvy every day, you'd be taking a new combination just once a week. And we may be getting additional protocols for once a week regimens as well. So I would say stay tuned if that's something that's interesting to you. You'd like to reduce your pill burden. I think it's excellent. We're running a phase 2 trial on one combination of 2 medications for once a week. And it's been life-changing for the patients who are enrolled in that study. We also have another trial with ViiV Healthcare looking at a broadly neutralizing antibody plus cabotegravir. And that one we screened 8 patients so far. It takes a little while to get back all of the lab work to make sure that everything's good to go, but quite a few patients are not meeting the criteria because the virus that they have is not sensitive to the antibody. So that's just one frustration with it. And it might be difficult for patients in San Diego because there are a lot of visits involved. You have to come in monthly, and it's like a 2-year commitment. So while we can provide the transportation back and forth, it might get tiring, to go from San Diego to Palm Springs. But I thought I'd mention it anyway, just because it's really exciting in the sense that you're getting an antibody infusion every 4 months, plus cabotegravir. And while cabotegravir is given monthly, they're eventually going to switch it over to every 4 months, and then you'll be on an every 4 months injectable regimen. What else? We just got selected for a PrEP trial for every 4 months cabotegravir. So that's going to be really exciting. It's a phase 2. And so we're actually looking for participants, diverse participants, either women, cisgender women, or non-white individuals. But that'll be, again, for HIV prevention. And I think those are the main trials right now. So again, like in summary, we've got an injectable trial, we have a once a week study, and we've got the bictegravir, lenacapavir. We got 2 of those trials, one for patients on Biktarvy, one for patients who are on complex regimens. And then we've got the PrEP trial coming up for every 4 months injectable. So I think I don't want to overwhelm everyone. We probably got more things in the pike. We always are getting really cool studies. So
Okay.
Can you hear us? Yeah.
a little bit, not so much.
Oh, okay. Let me get closer to the mic, I guess. Can you hear me better now?
Yeah.
Okay. No, that was perfect. Thank you very much. So what we wanted to point out is what is available in Palm Springs that's not here. And there are at least one study, right, that's available both places. And I certainly have patients that I don't know, their husband, their boyfriend lives in Palm Springs. So I don't know. There's all kinds of reasons to go out once a month.
Yeah, and we appreciate your referrals, Dr. Caperna. We've spoken to a lot of your patients, at least given them the information. I would say for the cabotegravir study, because there's interest there with the antibody, to be aware that patients who are currently on Cabenuva won't qualify because any exposure to cabotegravir disqualifies. Just as a heads up.
Thanks.
But yeah, no. Yeah, but no, thank you so much for getting the word out. We really appreciate it. And, we're doing our best to follow up with all the patient referrals. And most certainly, I think you have our information that you're giving out proactively to people. And you can give them my number as well. And I'd be happy to follow up with them personally.
Is the weekly study, is that with islatravir?
No, actually, it's a different trial, although we are in the running to get the phase 3 of the islatravir, lenacapavir once a week combination. This is a combination of 2 new agents. They don't have names yet, but GS1720 and GS4180. It's a long-acting integrase inhibitor and a prodrug of lenacapavir. So, yeah, it's different. It's a different combination.
Well, I think everybody here here's the advantage of these studies, less often. So less like havoc on your gut, right? If you're just taking pills once a week versus every day, or the injectable, obviously. And the neutralizing antibody studies that's real hope to crawl toward cure, I think, to be part of that. And then, yeah. And I emailed it out, and another email will go out later, but I put the link for BIOS, which is where Dr. Morkos is from.
And we have we keep in mind we actually are revamping our website, so we don't have all of the trials currently listed. But if you go on there and there's a form you can fill out, really easy, your name, your phone number, the type of study that you're interested in, either treatment or for PrEP, and we get that emailed to us, and then our team will follow up with you, so we can go into more detail.
Right. I saw that on the website. I went there this morning and there was only one study listed under HIV.
Yeah.
And I thought,
I know. Yeah, there's
okay.
a ton
Anyway.
going on, and yeah, we're in the process of updating everything, but hopefully it'll be updated soon.
All right. Any other questions before we let her?
Yeah.
Yes. Go ahead, John.
To all three of you, is there a renewed thought process about drug holidays? You know, where you go off your meds. I was speaking to somebody just the other day, and they were on their second drug holiday, and I was like,
Well, that's what the neutralizing antibody concept is. Hopefully we crawl toward longer breaks off meds. Or how do you want to comment, Dr. Marcos? About drug holidays, any kind of intervention that would lead to breaks in therapy, where I guess he's saying you would maybe go back on.
Yeah, there are studies with some companies looking at what we call acute treatment interruption. And so the idea with those trials is that you get on some kind of combination of agents, whether it be antibodies plus other immune stimulating agents, that over time that you can initiate or I guess like not restart your antiretrovirals, and just kind of watch whether or not patients rebound or how long it takes for them to rebound, and simultaneously looking at their CD4 CD8 ratio and increases in immune function. So we actually we're going to be at CROI this upcoming week, and we plan to talk to a couple of companies about ATI trials. I don't have the study designs for those, so I'm not quite, there's different ways of doing them and different kinds of agents that are being explored. And I'm actually really just learning about all of it. So maybe the next time we do a call, I can have more information to talk to you about those protocols and if we get selected for them. So
Acute treatment interruption. Yeah, I mean, yeah. Well, I think that the longest by any intervention is 6 months off treatment and everybody's virus comes back, I think. No matter what what we've tried to do, I don't remember anything going longer than that, with CART studies or whatever.
Yeah, no, there isn't. I mean, everybody gets virologic rebound. It's just a matter of time, but that in it of itself is a form of it's how we approach cure at this point, because we can't at this point total eradication of the virus is just we don't have a way of doing that quite yet. But functional cure, there we go, Saturday morning, functional cure is really where everything is headed. And so with these antibodies, so the study that we have where it's the antibody plus cabotegravir, while it's for treatment and there's no acute treatment interruption, that's part of the protocol. That particular antibody has been looked at in earlier phase trials and proof of concept. And what they noticed is that for a couple of the individuals in those trials, they actually had sustained virologic suppression, which basically means they were able to keep their virus under control for a matter of several months. And the length of time I think that patients are able to keep their virus suppressed has to do with also the pharmacokinetics of the antibody as well, meaning the drug concentration, the amount of drug that's of the antibody that's available in the system. These are long-acting agents, of course. And so, yeah, it's promising. And that basically means that it is eliciting an immune response in the individual to be able to further suppress the virus without the need for medications potentially. And so being on a treatment protocol that involves one of these broadly neutralizing antibodies could have that effect. And it's a secondary endpoint that's being looked at in these trials to kind of measure how just the immune system is responding, and who knows in the future what, whether or not they might have protocols where they do acute treatment interruption. Merck reached out to us. We will be meeting with them at CROI. They have acute treatment interruption studies with their monoclonal antibodies. And so we may be selected or at least be in the running for those studies pretty soon, as they're looking for sites for their phase 3. So I'll keep you posted. But it's exciting stuff. It's really cutting edge. I think one thing that really comes up for patients is I'm a little worried. Like, I don't want to go off my Biktarvy. I don't want to go off on the regimen. My doctor saved my life. I've been on this regimen. I've been doing really well. I'm really worried to be on this in this study. And, so there's a fear factor. And the only thing I can say about that is, yeah, you're taking a risk, but you're very well cared for. You're coming in to visits way more frequently than you ever would at your doctor's office. And so even if there was a chance where we thought this regimen is not working for you, or maybe your virus is starting to creep back up, we would be able to control that ideally before there be any real significant consequences. And so if you think about it too, an antibody plus a long-acting agent, whether it's with Gilead's lenacapavir or with us with cabotegravir, particularly with cabotegravir, it's not that easy to develop resistance anyway. And so ultimately, not these combinations not working out for a patient may not really have clinical significance, if that makes sense. And so you'll have plenty of options still to be able to resume your current antiretroviral therapy or otherwise.
Thank you. And that's that you said that very well. I was trying to point out the risks of research earlier, and I put it in a simple way. The shorter the amount of time off your usual regimen, the less the risk. And if they monitor you very closely, they can put you right back on your previous regimen, just for example. So you brought that up again.
Yeah, the studies that she mentioned.
Yeah, go ahead.
The studies that she mentioned are important. One of the key elements that's controversial about cure research is you can't tell if you were cured if you don't go off of your regimen, right? And so what they're trying to understand, and the risk there is if you go off your regimen, you may develop resistance, and either you become resistant to a single drug or a class of drugs. And for those of us who are long-term survivors, we don't have a lot of classes left, but we don't have a lot of class anyway. But
Dr. Morkos, can you see Michael Donovan? He's president of Possibilities, which is, I don't know, probably the largest social HIV support group.
Yeah, we're kind of the local version of Let's Kick Ass Palm Springs.
Right. Yeah. Well,
okay.
Yeah, no, I hear that for sure. I think one thing I would say, it's not going off of your meds completely that causes drug resistance. It's being on and off your medications, having subtherapeutic levels of medication in your body, allowing the virus to replicate in the presence of drugs. So, taking drug holidays is actually, depending on the regimen you're on, but generally speaking, if you're on any oral regimen, taking drug holidays, meaning not taking any of your antiretrovirals, that is not necessarily going to create drug resistance. Actually, it's probably a pretty safe thing to do. But aside from the fact that your virus is going to go back up and may have other effects, but for drug resistance, we're actually worried about patients who are, taking their meds one day, every couple of days, or every just once a week, that kind of thing, where they're just getting just enough drug exposure, but not enough to keep the virus under control. And that's where you get worried. In the case of clinical trials, these are new agents. And so we're just starting to understand or characterize their ability to get virus suppressed, and also their barrier to developing resistance. And we know that some medications have higher barrier to resistance than others. And so that is a risk, inherently in these trials, because we're trying to understand, is it going to be able to control the virus well? And is it going to, what's the likelihood that resistance can develop if patients are not, 100% adherent to these medications? But with that being said, lenacapavir probably has like a medium resistance, barrier to resistance, and cabotegravir has a high barrier to resistance. So, there's some information that we know with some of these combinations because the medications are already out there on the market. Now, again, you're going to be coming in for visits, and so for us to be able to detect that you're viremic or even having a blip is going to be way easier. And we'll be, you're going to the doctor's office every 6 months. You don't know how many blips you've had in those 6 months. We're going to be able to catch you the second you're over 50 copies and be bringing you in every couple of weeks to make sure you go back down to undetectable. So you have very, very close monitoring. So again, it's to decrease the risk of you developing drug resistance, as a result.
It's because the drugs are better now that potentially you can go off at some point. Because I went off when I got pancreatitis, which was about 15 years ago. And it was suggested I stay off my drugs because nothing was going to go through me. And within a few months, I was up to 1 million copies of virus. I mean, it just came back.
It's a pretty constant, every whether intervention or not, if virus is suppressed and then someone goes off therapy, everyone's virus comes back in 6 months, right, Dr. Marcos? It's just a constant.
Yeah, I mean,
really,
some
really
quicker
bad.
than others. Yeah, of course, Dr. Caperna. And it depends also how long you've been on antiretroviral medicines. It may take longer for someone who has been living with HIV and have been on meds for 20 years to have a viral rebound compared to someone who was recently diagnosed and only undetectable for the last 6 months. There's a viral reservoir. So there's also a concept of being on long-term antiretroviral therapy may be affecting the amount of virus you have in your reservoir. And if you don't have very much, then it takes quite a while for it to come back. But everybody is different. And to answer the question around coming off of the meds, it's because, as far as drug resistance is concerned, so I'm a pharmacist by training. Everything has to do with drug concentrations, and do these drugs have well matched what we call pharmacokinetic profiles? And so if you, for example, if you go off of Atripla, efavirin's one of the components that seems to stick around longer in the body than the other two components of the combination. And so if you come off of it, technically you still have lingering levels of one drug, and therefore you have subtherapeutic levels. You're actually going to be able to develop resistance to that particular component.
Interrupt just a second. You just opened a huge can of worms that patients have been asking about. The great worry with these long-acting ones is they're going to be sitting around by themselves or not matched pharmacokinetically, like you said. So maybe next time you talk, you can address that worry about anything that's long-acting.
Yeah, I mean, I think ideally if you're coming,
we got to let the group know, but yeah, go ahead. I'm sorry. Go ahead.
Yeah, no, I was going to say, I mean, yeah, of course you're worried, but I think if you're switching out from a long-acting to, let's say you're going back on your regimen, the key is that you're on a complete regimen that should be able to suppress the virus. And so whether or not you have those other two or however many long-acting agents still in your body, is probably not going to matter with regards to keeping the virus under control. Now, whether or not there's side effects for having so many medications in your body, then that's a whole other question. But yeah, I mean, I think you bring up a good point. I mean, you can't just go off of these long actings, possibly, they're lingering levels and they may be around in the body subtherapeutically for a longer period of time and may lead to resistance down the road. So you need to make sure you're covered or you're switching to another regimen pretty soon after.
Right. And then the unknown long-term side effects of these meds that are at least in the body for 6 months, if not lingering longer. Wow. Well, we really appreciate your time. Do you guys want to ask any one last question or just say thank you?
Thank you.
Thank you.
Thank you.
Oh, thank you guys.
Well, fill out the questionnaire if you can. There's a little part on the back about exercise, like do you exercise, and and if you don't, what prevents you? Is pretty much it. Because that's, I think, where Michael and I are from possibilities. This is not something that needs to be researched. God, I looked at everything I could get my hands on with HIV and research, or HIV and exercise, and it's been studied enough. It's just beneficial. And a local researcher, Dr. Jan Lee, wrote an invited editorial about HIV and exercise, and that it's clearly beneficial. So he kind of sounds, the subtext was like me, like, why study it anymore? Just encourage it and support it and figure out what you can do. And he makes a scientific point, which I think is important, which is if people are getting weight gain related to HIV or the medicines for HIV, which we see as abnormal, like trunk and neck fat, does exercise actually help that? And it's yes, studies so yes, at least somewhat. So have hope that if you're one of the unfortunate people that gained weight, certainly common on the old meds, which is still like sitting around, and you can still make it better. Some people, I mean, it's a pretty fit looking group of people today. Or if it's from the newer group of meds, which actually the pharmaceutical company said at first, oh no, it can't happen to the integrase with the integrase inhibitors. Well, yeah, it sure has, and they've shown it that get back to simple, that we don't have to study it.
But don't we have
Exercise
Dr.
can
Lee
help
on,
that.
don't we have Dr. Lee in the queue somewhere to come speak?
Yes, so that gets us to the next thing. Good segue. Please write down suggestions for future topics. Wanda has offered to help us organize a spirituality and HIV talk to be holistic.
Dr. Lee is also very.
And then we're going to do, I don't know what we want to call it, lipodystrophy. We have to come up with a title first, but it's like, it's shapes and weights you don't want. And I guess we're going to talk about more of the excess side.
What if you never have
and also have a plastic surgeon come. Go ahead, yeah.
Dr. Lee also is an expert and he did a study on Kili meditation, which of course meditation.
And she brought that up and she loves it. And so we would unify that.
I call it meditation for people with ADD.
That's a way,
It's only
baby.
5
Right.
minutes.
See if you can invite him and get him to come. Because we've been wanting him to come for metabolic reasons.
3 hours.
And maybe he'll come as a
speaker.
Minister Lee.
Yeah. Well, actually,
No,
really
shut it up.
meditation is medical, but it's a 5-minute quick way.
And he
to
knows
get
him
all this
super
stuff.
well because he's president of Being Alive.
Yeah, so, but I'm his patient.
So am I.
Yeah, I love him. But
And he-
anyway,
okay.
I did the whole Keeley workshop with him on a weekend for the med students, the first year med students at UCSD. And it helps to be able to take 5 minutes to clear your mind and get yourself back to center. And he's been doing it for over 20 years, so.
And other topics for suggestions to talk about that. We're going to have something on spirituality, something on lipodystrophy. We're going to have next month is really important. The largest scientific conference, yearly conference on HIV is CROI, which doesn't have HIV in the title, but it's the Conference on Retroviruses and Opportunistic Infections. That happens like next week. So Dr. Sarah Brown is going to come talk about that. The other part of next month is going to be designing a local study to use amphetamine for methamphetamine withdrawal. So that's the next meeting, and that's enough. And it's hitting our whole community. And even if you don't want to participate or need to have a need to participate, I bet you know somebody. That's a huge hot topic because it's like playing with fire or something. I don't know. Everyone's like afraid to talk about using just analog therapy like we use with opiates, right? We use methadone and buprenorphine for opiate addiction, and to help people ease off during the 2 to 4 weeks, apparently, which is acute withdrawal from methamphetamine. You can ease them down physically. And then there's the whole psychological, which goes for like a year or two. But medically, it makes sense. So the biggest resistance actually is we can't find a UCSD psychiatrist who wants to do it, but Dr. Brown and I want to do it. We just want to find 10 people to study it on. It's never been studied in HIV.
If you're doing
this approach. Oh, right.
Dr. Roger Paul is really doing a real good job with AIDS and addiction enrollment clinic right now. It's amazing what her results are. And her husband also is a drug and alcohol counselor at the San Diego Detox Center. And they give a wonderful co-presentation. So maybe we can get them in sometime.
Yes.
They're good.
We'll invite them next month.
They're really good.
And Dr. Montoya at UCSD is doing a study of methamphetamine, trying to stop methamphetamine with a financial incentive.
Right. That's funny.
And it's true. And it sounds silly, but if you're a sales guy, it can be pretty motivating.
Right, one of our speakers here talked about it.
Yes. And as I said, for those that are motivated by goals and quotas and things like that, it can be very motivating.
They don't know the trials for like
And I'm sure she would speak
making
about
medical appointments in general.
Yeah.
To some success,
Yeah.
which is kind of interesting.
it. I know her quite well, so I'm sure I could hear her.
Okay, yeah, maybe for
At some point.
maybe for next month. The
I'll
married
send them a
couple,
note.
are they married?
They're
Yes.
married, yeah.
Uh-huh.
Yeah.
Oh, Dr. Roger Paul and Neville? They just got married last year.
Oh, okay. Whatever.
They've been living in sin for 5 years.
Checking up.
Is there such a thing?
Could you write those names down for me?
I'll put Dr. Roger Paul's email.
Good. Okay, yeah, just write it down for me so I don't have to
Yeah,
forget.
that's
Thank
good.
you very much.
And I'll send a note to Dr. Lee.
Okay. Oh, sorry.
So Michael will present
I
more
was joking.
on,
Minister Lee. Please invite Minister Lee.
Michael, when is the programs for possibility going to start?
Probably in May, basically waiting for weather. We work out in the park. So I don't want to do it during the
Now,
rainy
for
season.
those of you that have any interest in doing exercise, you can,
We'll be
Michael-
able to announce what the program
Yeah.
scope and structure is at the end of March. So in the April meeting, I can talk more about it.
if you didn't hear, last semester, we had Tai Chi and physical fitness and nutrition.
Mhm.
Nutrition class and physical fitness with a trainer and the Tai Chi class with an absolute master. And they were great. They were fantastic class. I couldn't go to the nutrition because it conflicted with the yoga class. But if you guys imagine this, if you could do all of it, you may not be able to, depending on how many. But if you can do the Tai Chi, the physical fitness, the yoga, and then our substitute teacher gives a discounted rate for yoga in the park, man, it doesn't get any better for HIV with that, I tell you.
I see them doing it in the park all the time.
Yeah, and you know, our Tai
It's
Chi
almost
teacher
something
told
every day
us,
of the week.
Mhm.
told us
Actually,
you can
you
practice
clear
your
the
Tai Chi
center and
in a space between these two tables, and that's it. And get as much out of 10 minutes of that as being on a treadmill for 45.
Wow.
And he knows his stuff. And Michael goes to him privately. So Michael, you can
The
speak to
trainer,
that.
yeah. Matter of fact, I just came from there.
Yeah.
The Tai Chi, okay.
The
Yeah.
Tai Chi, we'll be working with him again. We'll be doing 2 classes, one that's a continuation of last year, and one that's for beginners.
And for the remedial.
And for the personal trainer, it'll be one group, but it'll have every exercise will have a basic and an advanced version, so you can choose whether to push yourself or not.
This all takes commitment, you know, and takes
Yeah.
belief that exercise is going to make you feel better and live longer. Nothing's painless. What do you have to offer, Wanda?
Just FYI,
Yeah.
for anyone who has challenges with movement or struggles with arthritis and weight training, that's good for it. But there's also Aquafit at Bud Coon's pool 3 times a week. I do that.
Oh,
And you don't feel, and it's a major workout in the water, but you don't feel like you're doing anything, but your body shows.
Can you write that down for me?
Yeah.
On the back under exercise?
Yeah.
I'm adding it to this list, like somebody.
Yeah, I do that. I do that 3 times a week.
Right around the corner from where we do Tai Chi.
Yeah, I see
Wow.
I see you out there in Tai Chi all the time. As I'm coming from the pool.
And the center does exercise 3 days a week.
Yes, and that was added too. So Michael,
Yeah.
pointed me to that.
You know,
And the Aquafit
1:30 to
for
2:30
seniors.
on Monday, Wednesday, Friday at the center. It's
it's
called 50 and older
Yeah.
something.
Well, the
Basic
Aquafit is not Monday, I'm sorry, Tuesday, Thursday, and Saturday from 9 to 10. And it's like you can get, for senior price, it's like 30 visits for like $20.
And
or
it's
something.
warm.
I mean, it's warm enough. I mean, because what happens is when you get in, your body
That's
heats
so
up. 'Cause
old.
I do the ice.
Yeah, I
too.
know. Nothing's painless.
how many
right?
people in here feel like they've gotten something out of coming to these meetings? That you're more educated,
Absolutely.
that you ask more questions, and that you know where to go for answers too.
Yeah, it's a good program you're running.
I'm going to ask all of you to just do this. You know, help us with this meeting to just grow it, and by that I mean when you get the notice, try to get 3 to 5 of your friends to come to this thing because it is so
And
important.
$1.25.
I have a suggestion.
Hey, you get your
I
SAE
just-
valve.
No, but yes, we are asking for help. Yeah.
You get SAE
hate asking
valve.
for help.
We're getting more women here.
Yes.
One of the
Yes.
things that came up today that resonated with me is that first of all, you're asking about what we want, what we need for
Yeah,
our own health and lives. You need to do a straw poll or a survey at Chrissy's place and at places where women go and let them send to you what they need from you, and then maybe we can
We've
start
tried. We'll
attracting
send you
them.
over there. They did show up once because a Christie's Place woman, Leona or somebody, ended up in the HIV and Aging International Workshop in DC
Yeah.
with the possibilities people, right?
Yeah.
So that was a natural. They actually showed up and we actually worked together. Otherwise, I invite them every time. We go actually directly to them. We drop off 10 flyers. We've asked them what they want to hear about. I'm just telling you exactly what we're doing.
I could go there.
Yes,
if I
that's
have
right.
to.
Yeah, rewind what I said 2 minutes ago. Right, yes.
Yeah, I'll
Why don't
just
you
go
go?
there.
Yeah.
I'll just
One of
go
the
there.
questions I would send around to all of the agencies
Yeah.
is about timing.
Yeah.
For example,
Oh, yeah, what would be
Possibilities,
good?
I'm working with coffee, so I
Yep.
can't get it.
Yeah.
So if you could move it to 11 instead of 10, even something that's.
What do you want to do next month? You want to move it to 11 just for that reason? And then they would really try to keep us to 11 to 12.
Yeah.
And we won't have like 3 topics. We'll have 1 topic at a
That'd
time.
be good. I know a lot of
Certainly.
people don't
And you can bring
get
sandwiches instead of donuts.
So 11 to 12 sounds okay. Okay. So next time it'll be 11 to 12.
Okay.
We'll just make it easier. Acai bowls. Apparently, that's a big hit.
Well,
That is
then you
a
can
big
bring
hit.
sandwiches instead of donuts.
Sponsored by, because I said acai bowls sponsored by. You sponsored it.
Hey, Michael, you want to mention the survey? I have something.
Yeah, I will.
Ish.
Also, for those who aren't aware, the HIV planning group, the Ryan White funding allocation group in San Diego, is running a mandatory 3-year needs assessment survey. I should have brought a flyer for it, but I can make sure you have it so you can distribute it with your
Yeah, happy
your
to.
note.
Yeah.
Please consider taking that survey. They use that to determine where the need is and how they can allocate funding. There are some government restrictions on the fact that it has to go mostly to medical care, but the results of that survey are important to how San Diego gets funded for HIV care.
How many people are alive with HIV in the county? 13,000?
14,500.
14,000.
And where do we find that survey?
Yeah.
I'll send the link.
Okay.
It's listed on the Possibilities Facebook page and website, but and also on the county HIV planning group website. But I'll make sure he gets it and he can send it out.
Thank you.
You know what I would add to that is they were talking about exercise and everything, and maybe you bring somebody in that can speak on mental health, less exercise, combined together. Because that's important.
It's, yeah, the dopamine and serotonin and stuff.
It's very
Can maybe work with Gabe from down at Family Health Center.
And isn't it very wonderful that HF allows us to use this?
Yes, thank you, Eric.
Yes, it
Yes,
does.
Eric puts unpaid time in.
There's a new group that started here on Tuesdays at 1 p.m. for HIV or anybody. It's open to everybody, and you get a free lunch. So show up.
What is
That's
that?
always a plus.
It's a partnership with Neighborhood House Association. So we have partnered with them to offer case management and support group here on Tuesdays.
Yeah, because the county has no HIV case management except for people who inject drugs. That's it. And so that's wonderful.
Technically not true.
Native American Health
It is
Center-
too. I have tried so many times. I've gotten rejection letters. No, Dr. Moore, I'm so sorry. This person doesn't inject drugs.
The Native American
Yes, I'll
Health
show you the
Center is
letters.
not doing case management too. They're gonna build a.
Heidi
sensory
sent me the
building.
last one.
Heard Ryan White,
I
they
mean,
do fund
who's
it.
really would try for it, right?
They do fund a number of agencies for case management.
What about if you snort it through?
Right, oh, that's the argument. Oh, I'm so sorry. But they only do ADAP now. I think they're 99.9% ADAP, aren't you? Being alive, which is super important. Oh my God. To make sure that everybody gets their meds. Yeah. All right, well, this is a nice meeting. Thank you so much, and we'll see you.
Wait, we have what? You asked me to come and.
Oh my God. Oh, I'm so sorry. Right. Okay.
Oh my
So,
goodness.
yes. This will just take a minute. This is just really that nutrition and supplements came up a lot, and nutrition is probably going to be in a couple of months. And I asked John and some other people to highlight what they do that I think is medically useful. So there's plant-based, I don't know, additions to the diet. If you don't call them supplements, there's Juice Plus and there's these other things. And so he's just going to talk about
Juice Plus.
What will that also, and what he knows about nutrition kind of quickly, you said, right?
Yeah, it'll be pretty quick.
Okay.
I got about
Thank
like
you.
10 minutes. Maybe.
All right. So this is how also to open this up to like 5 minutes for people in the group, right? That have something useful that our little like board of 4 thinks is okay.
Well, also
yeah.
the topic for the meetings is diabetes specific. The speaker on diabetes specifically.
We totally need that. My God, yeah.
Mhm.
Because
And heart
so many
disease.
people have. Yeah, we've done heart disease. We're going to do that again too. Yes. Yeah, it's too many heart attacks. All right. Well, anyway, John's like a long time friend and patient.
We're all patient.
I've been in his gardens. Anyway, he knows
We
a lot
try
about.
to be patient.
Yeah, he knows a lot about plants.
He does. He's been written up. John's been written up and he's been on TV. He's been featured on TV.
Yeah, he's an award-winning landscape architect. actually.
Absolutely. He
Nationally.
builds beautiful flower gardens and plant gardens
But-
and with unusual plants that what's popcorn? Which one's the one that tastes like
Popcorn cassia.
Yeah. See? There's just things that are very original. He's been featured many times.
I didn't even know you knew that. Thank you very much. That's
And
very
how
nice.
did you land on what you're going to talk about?
Me?
Why you think it's important?
I'm going to tell. So, full disclosure, I'm a distributor of Juice Plus, and the other piece of that is like I'm not interested in being a distributor of Juice Plus. I'm in it to get a discount on the products and for possibility of what's there. I think it's a great product.
And you like it.
I actually don't like taking it that much, but I think it's good for me. And this is it. I'm going to put these three together. And I'm mostly not going to talk about these products. I'm going to talk about I'm going to talk a little bit about my story and who I am and how I got here. Because I think it's really important that we connect with each other and understand and know who we are. And I haven't been active in participating in possibilities or much of the. I've kind of dropped in here and there. I came here in 2010 and just poured my work, all my time into my work and building my business. And I'm in the process of getting myself out of my business and giving myself more time to
enjoy my life because, like, what the heck am I doing here anyway? The idea here is one simple change: just start taking a food supplement, and we'll get into what that is and why. So this is my husband. It's not right here, Luis, and in the middle is my nephew. There's a long story about him, but I won't go into it. He's I mostly don't know him, but I got to spend some time with him recently. He's like 45, spent most of his adult life in prison, and it's a long story, but he's back in prison now, unfortunately. This is my company, Beaudry Garden Design. Like I say, I started after my first garden, 5 years old. It's all I've ever done. It's my vocation, my avocation. I'm a plant nut. I was diagnosed HIV positive in 1985. I was 25 years old. For those of you who are around at that time, you know that getting HIV was a death sentence at that time. I waited 11 years for the axe to fall, and while looking for all the while looking for signs of thrush or lesions on my skin, wondering, have I got it yet? In 1993, I got a sinus infection. My doctor said, well, we'll give you a course of antibiotics. If that doesn't work, we'll put you on IV antibiotics. If that doesn't work, we'll do surgery. And I was like, what? And he said, you don't understand. You don't have an immune system. All of that came to pass. I spent that summer on IV antibiotics. In the fall, I had surgery. Then I developed bronchial asthma, then pneumonia. I lost 20 pounds. I said goodbye to my family, my friends. I wrote my will. I bought a house that would accommodate a live-in nurse. That was a rough time. The following February, the cocktail came out. I got a complete restart. Like within 30 days, I was a completely different person. I learned a couple of things really, really well. I learned a lot. Number one, that when my life felt out of control and I had no place to belong, it was when I was in my garden, when I had my nose in the blossoms of flowers and my hands in the soil, that I felt whole and connected to something much larger than myself. And that connection is what we all need. We need that connection with nature and with each other. We are part of nature, so we need to be with nature and with each other. And everything in the world that's happening is driving us away from each other and into ourselves. And I really feel it's incredibly important to do that. So much so that I've created a nonprofit called Community Green, and it's dedicated to implementing green infrastructure in cities to manage our water, air quality, and temperature, so that we can live in harmony with nature instead of against her. And there's all kinds of rooftops, public rights of way, alleyways, vacant lots that can all be used for gardens, places where we can come out of our homes and into nature outside, be together in a healthy environment, whether there's a pandemic or not, and connect. And number two, I learned that if I want to survive, I've got to be my own advocate for my health. There's so many conflicting, I've been on countless diets. I've taken tons of supplements. I've listened to traditional doctors, Chinese doctors, nutritionists, and I've taken incredible regimens of supplements from listening to a Chinese doctor and taking 5 or 6 different things from him, or then going to an acupuncturist and getting things from them, and going to a chiropractor and getting a whole different set of things from them, and spending tons of money on all these supplements. And recently I spoke with a naturopath, and I said, he said, what's your goal? And I said, well, to feel normal. And he said, the first conversation we had is like, we need to set expectations about what normal is. As a fact of life, you're taking all these medicines and they are having an effect on your system. And we can't get you to normal, but we can get you to better. So all that we're doing is really helping with all the side effects and kind of beginning to ameliorate them without crippling us. And the other thing you said, everything you put into your body has a chemical reaction, and they all react with each other. So one of the first things he did before he made any assessment of me was to do a compare, like, I guess there's some software you can put out and you send it to some lab, and it tests it looks at all the different interactions between all the different drugs that I'm taking. And another thing is, like, all of my complaints were, brain fog and not having enough energy and having gastro stuff and were the top 5 symptoms of most of the drugs that I was taking. And all of the interactions caused more of the same. So, and then you throw in supplements and they start interacting with those things too. And we don't know, we can't calculate all the different things that are happening when all those different things are going into our body. So I stopped it all. I know a lot of people who believe that our bodies have the intelligence to heal ourselves. We don't need anything outside of ourselves. And yet what we have to feed ourselves. So like only to really, I stopped it all only to come back to nature. Like maybe we can maybe our bodies are enough. And then like, why do we even need supplements? And can't we get what we need from the food that we eat? And the answer is not really, because we can't get all the nutrition from the vegetables we eat because there's 2 limitations. It's just not, it's hard to eat that many vegetables. And for a lot of people, they can't even afford to get them or have access to them. So, or even know how to cook them. A lot of us live alone and are kind of isolated. So it complicates it tremendously. And then 2, the vegetables that we eat don't have the nutrition that we think they have. The U.S. dietary guidelines recommend that both children and adults eat 5 servings of fruits and vegetables per day. That's equivalent to 1.5 to 2 cups of fruit and 2 to 3 cups of vegetables. Who eats that many? Good for you. If you're on a plant-based diet, you might be able to. But the other aspect, according to National Geographic and many others, there's mounting evidence that shows that many of today's whole foods aren't packed with the vitamins and nutrients that they were 70 years ago. And this is potentially putting people at a health risk. So think about this. What are vegetables made of? It's really mostly water. In fact, they're 90% water. So what if we could, since they're mostly water, what if we take all that water out of them, shrink them down, grind them up, then we could eat a lot more and it would make it more accessible. So then I learned about Juice Plus. And basically, there's these, this is called the trio. This is berries, fruits, and vegetables. Between the 3, there's 40 different fruits and vegetables in these. And the idea is that you take these and you get all the nutrients from all the colors of the rainbow, basically, in the food. And where's my little chart here? They're, so it lists on the bottle what they are. They're food. They have a food label on them with the FDA. So it's not a supplement. It's actually just vegetables and fruits and berries in these things. This is an omega blend. And when I take this, my cholesterol goes down by about 20 points. So they're bioavailable. They support immune function. They provide antioxidant production. They decrease biomarkers of inflammation. They protect DNA from oxidation. They improve key cognitive processes. They support healthy skin, support dental health, cardiovascular health, lung function, metabolic health, exercise-induced oxidation, and support gut health, and increase the omega-3 index. And you were talking about the biome of the body. It actually helps that. And who says that that's true? There have been over 40 research studies done by independent universities that have studied all aspects of these, and they say that they're good for all kinds of things. So the research goes on to say that the bioavailable nutrients, they work with improve immune function. They have antioxidant protection. So you're taking all of these, what are they called? That reduce free radicals?
Antioxidants.
Antioxidants that are naturally occurring in these foods. And all the food is raised organically by farmers that have very high, strict standards beyond organic. And so these are really safe. They provide dental, I've already said this, dental health, cardiovascular health, DNA and nutrigenomics, and healthy skin. I mean, it goes on and on.
Still not studied in HIV, and so like everything separated by 4 hours from your meds, because it usually takes 1 to 2 hours for the stomach to empty. So you don't want things in there at the same time. So usually most doctors will say,
That's
2
first
or
I knew
4
that.
hours.
I've always taken them together.
Well, you
That's good.
probably can.
I would
it's
rather because it's a
probably
lot of
only
pills to
food,
take.
But it brings up the problem that came with like garlic, concentrated garlic extract, right? Which was interacting with the previous HIV meds. And if you just used garlic in food, that was fine, right? But not if you concentrated the garlic. I don't know. Those things haven't been studied. I don't know what happens if you concentrate a broccoli or something.
Grapefruit juice also.
Yes, and concentrated. It's much different than just drinking a little bit.
So this isn't this.
So anyway, I really think this is safe, and I think it's a good idea. You have to make sure you feel better afterward, right? If you're going to spend this money, and the whole point was for John to bring up the topic of nutrition with your medical provider, and to be more specific about supplements, or people don't like to call these things supplements. They're additions to your diet because they're not really a supplement, right? Like you said, they're food. What else can I do, doctor, nurse, wherever you're talking to, right? In addition to my food.
Can you?
In addition to the food. This is what we're talking about. Of course, eat healthy, but in
No.
addition to that, you know, supplements, vitamins, minerals.
That you can't live on these.
No.
This is not a complete diet.
Right.
It's
in addition to your diet.
It's
is
all the
topic.
vegetable servings that you need that we don't get.
And what about
Right.
diabetes? Just touch on that because that's so important to this room.
I can't really speak to. I'm not an expert on that. I don't know.
Okay, good answer. Okay. All right. But in all those research studies, there's something about diabetes.
In the end, I'm going to put up a QR code, and you can. We'll give you a link, and you'll have access to. It's a little page that I created for myself. It has a little video from me. There's all the. You can order it. You can look at research studies. You can like a wealth of information there.
Maybe from the company, I bet that they have something on diabetes.
There are fact sheets on about 60 different diseases that have been studied in regard to these I was going to call them supplements, food powders. Again, this is some overview of the research findings, which I already went over. And what else? This is what they look like: whole food nutrition in a capsule. And Dr. Caperna said that he had tried them, and he didn't like that they gave you this kind of like, what did you describe it like?
It was too much plastic. I just kept burping them. And,
yeah,
I tried hard I tried twice, a couple of months in a row. That was just my particular reaction.
I get the same reaction.
Oh, really?
I have, and it's gone away. I mean, it did for a long time. And they have chewables that you can take instead. So they're like gummies.
That's better.
And they have exactly the same thing. So
They now charge you 10 cents a bag with plastic.
I have a good question.
Yeah.
Did they say what their sourcing is for how they get the vegetables and fruits that they're dehydrating?
Yeah. They have tons of videos and stuff that are available.
And is the research funded outside of independent funding for the research, or is it funded by the company?
Independent.
So I don't have HIV. I don't take HIV meds. So I don't have a medical condition where I think that the meds are like taking minerals out of my body. But there's a lot that happens in people with HIV that
doesn't happen to other people.
Yeah. And so that's why I support adding something to your diet. I'm not sure what. I think this would be one possible thing to add. You can't add a million
things.
things.
Companion to your normal
So
diet.
I figure you can't go wrong with eating more vegetables.
Right.
It can only support us.
Yes.
I don't notice a difference, but I know that my body is. I mean, I'm
better.
I'm survived heart attacks. I've been through the ringer. And then another great thing about this company is the Healthy Starts program. So when you take Juice Plus, if you know a young person in your life, it doesn't have to be related to you. They're between the ages of 4 and 25. The company will give as long as you're taking it for yourself, the company will give it to that individual from 4 to 25 for 21 years, free. As a means of, I mean, the whole idea behind Juice Plus is like a food revolution that they also offer grow towers. They offer food powders. I didn't want to go into all the other stuff that they offer because it's just going to get too confusing. I just wanted to focus on, I'm doing this. It's working for me. It's one option. It's not the answer to everything.
Practical, specific example instead of talking about a broad topic.
I have a quick comment.
Yes, please.
which goes to your point. I love that this is a good companion to your normal diet, whatever that normal is for you, because you need the fiber, etc. But the one point that's really important is that you do it in conjunction with your physician because he has access to your labs. And for example, I can't take anything that has the fructose or the natural juice fructose because it will raise my blood glucose.
Mhm.
So it's important that your physician work in conjunction with
Absolutely.
you taking anything.
And one example, potassium and sodium.
Yeah, it could be a problem.
Like that came up with coconut water recently.
Yeah.
There's a lot of potassium in it. So if you have a heart condition or some problem with your potassium,
There you go.
high potassium, you don't want it.
Right.
Yeah. And anyway, so that was one thing that I can't remember the sodium potassium comments on those.
Right.
All right, we should probably tie it up.
Yeah, this is it. So
Magnesium, I have to take magnesium from downstairs. I'm doing a different kind of reactive magnesium instead of regular magnesium because they also go with the labs to see what's going on in your individual body. So it's really important to do that with your physician.
absolutely, I totally agree.
Yeah.
I
Go
do
ahead,
agree.
yeah,
So everybody always wants to know how much cost.
So, the fruit, berry, and vegetable blend, if you just take that, it's $2.67 a day. You can pay monthly, $80 a month, or you can buy it all at once for $320. If you want to get the quad, which is the berries, fruits, vegetables, and the omegas, that's $375 a day, $112 a month, and $480, I think, if you want to buy it all at once. These are the other products that they serve.
It seems like a big chunk of money, and yet I think about the amount per day and what it would cost to buy that many vegetables. It's actually pretty reasonable.
If you cut out Starbucks every day, then you probably will have more than enough money for it.
Exactly.
I would just repeat, I strongly recommend that you have to feel better after a few months and not like, that's my medical recommendation.
Yeah. Yes.
Your bowels gotta be better, something's gotta be better.
3 months supply? What do you say?
I think it's a 3-month supply. Yeah. Yeah.
Okay, anything else?
Well, so if you scan this,
Yeah.
again, it will give you my contact information and everything. So, and if you have a question, there's a place to email me. I check my email religiously. I'm in business, so I do all the time.
Yeah. Thank you for your patience with.
Let me just leave this up.
Thank you.
Yeah, that's where they start. So, John.
Yes.
Beaudry.
Yes.
No single-use containers.
That's really
And plastique. But anyway.
a very good comment, Doctor. I would suggest you write the company.
It's not working.
The more of us that do, the
Well,
better.
anyway, yeah, well,
The better that response.
yeah.
I could go
I
on.
don't know what we're gonna do about that, but I still think the product is safe, and I have plenty of patients that have felt better on it. And a couple that bought a tower, which I don't think you really need in San Diego, but it's pretty convenient to grow your own food. I mean, you can actually grow vegetables, not more than just lettuce, broccoli and stuff inside. It takes effort, right, to be a farmer, but
I'll blow it up.
no, it doesn't. It's just a little tower you put inside your house. All right, we're done.
Well, you know what? Thank you, Dr. Whitmer. You know, I don't know anybody else in this town that has done more for the HIV than you, and you know, I sure appreciate it.
Oh, there's plenty of other people.
And I don't know if you're planning on retiring, but I hope not soon.
I'm gonna do something until I drop.
Yeah. Here you go.
Maybe not full time, but yeah. Yeah, whatever you can fill out.
Thank you very much.
Look it up. I mean, there's so much research.
Hey,
that's been done.
Truvian.
Okay, cool.
Right. I know.
Oh, yeah.
I'll fix it when you're
I got it.
And I just wanted to say the, do have free. So I think the talent. you know, when Dr. Smith was talking about the cartoon, everything was in place for me. I used to work in the San Gabriel Valley, so I know people in that area.
Do you have another one of these?
Dr. Lee.
Do you have another one of the forms?
My problem is AIDS diagnosis. And so I kind of want to be on like a list for first on the list for phase 2. Exactly.
I mean, I am keeping track of people that are interested. Whatever it is.
Yeah. Right. So put me down.
Yeah.
I want to try to extra one.
Okay.
I ended up having
Did you read
having
Dr.
a
Lee?
different card and 100%
And he didn't want it, or you were getting?
Maybe right on, yeah.
Yeah. Okay, okay.
I actually
Hurry to the next meeting or whatever. Alright.
Even more recently, I was having chest pain.
That's the second one.
I was in the hospital for 3 days.
So that talks about that's why it's on the
So they yell at electrical problems, so they're losing.
Oh, we talk.
And he wants to be more active in the HIV.
Well, that's why I wanted to share my.
So ask him to come to these meetings. I mean, this level that the doctor can learn too. Yeah.
Hey, sure. I was with you way back when at UCSD, and then my insurance changed, and then you went with Gallery first, or whatever.
I went on my own.
And I think that was fine. And I talked to Robert my HIV doctor in primary care was and they stopped taking it. So I was in the process of changing the chart to try to get back. So I got two different things from Robert. One, he said, you don't do primary care. And then the other person said, yeah, you do if you're HIV positive. It's okay.
So that's the exception. It's hard to say both.
So then I asked her, well, what do I have to do with the chart grant?
Yeah, it's definitely a tough
And
thing.
so,
This year,
okay, because one person said,
It's more like find out
I'm gonna go.
okay, so, well, cool. But I'm in the, Dr. Dever was, my primary and my HIV
Right.
No, streptococcus. And I had scans, and they stopped taking it.
Well, yeah, I'm hoping it'll be a lot easier.
And I lost my.
I don't know that every year.
So I have. Yeah. Okay. And they also said, along with that, I have cow.
Formally, I did my stuff.
Did you write your name down today?
I think.
All right, let me see, and then I'll just ask my office to look at my data.
Okay, yeah, I'll either reach out or, but I know the coordinator, she can reach out to you directly.
Absolutely.
And the only thing for that one to keep in mind, right, is they're gonna want a recent job result, I think the past 6 months.
Thank you very
And
much.
it shows elevated levels of.
Oh, okay, right, the one that I had.
Dr. Berluzzi said he's come back.
Good question.
Were you here for Berluzzi's talk in January?
I have
Okay.
but recently, I had an ablation and so.
Oh, mine's Carl.
My EF went up
Oh,
from
yeah?
38% to 50%. So I don't know if it's.
She'll have it, I don't have all the.
Okay, all right.
You ever go to
Okay.
I first came to you after that, I don't know if you remember.
Here's somebody's pen.
Who
grabbed the pen?
Oh,
I haven't really done much with it
Yes.
for a while.
And
You know what?
you probably,
Singing with the choir, the voices.
I was with him when
John?
we brought him in, he was almost dead from encephalitis or whatever. And then he became a doctor at UCSD
all the time.
for you. My
You're
insurance.
saying about being live.
But it was
I
a long
need to
time
see the
ago.
coordinator with the
Yeah, because your
other
name
coordinator.
it seemed like a month or two ago. You
We gotta play all the
Uh,
time.
anyway, I'll
But once
bring
a
it
year,
back
as a
up
matter
on
of
Monday.
fact.
Okay.
That's a good
Okay,
version.
have a good weekend.
You too.
Would that be tough?
Who's your coach care
Yeah,
provider?
confirming that you changed the time to 11.
What's the play?
We just did, John, didn't we?
John,
Yeah.
Who dropped their
That's
pen?
his best.
Diamond,
Go out on Friday.
what's the play tonight?
I'm gonna keep it.
Blood or something?
What? Might drop a pretty pen. Oh, okay.
Darn it.
I should have spoke more
I
quietly.
have a possibilities flyer.
Are there readings in there?
No, I would like one.
There's readings in that
I haven't
book?
even, I haven't
There was.
participated. You know it.
See what's going on.
don't know if there's.
Oh, it's not right across the street.
Yeah.
Oh, I already have one. Okay, well, was it a rolled one?
February.
Oh,
Is it yours?
look how that happened.
No.
Well, let's say hi to you.
Hi.
I'm Ruben. I'm new here, so I just want to meet
Nice to meet you.
I
Yeah,
heard
you look like a
very-
new face. Yeah.
Yeah, I heard many good things about you, so thank you for.
How'd you hear to come?
I went to the Pride. That's where I pick up my meds.
Oh, from the
And,
pharmacy.
yeah, the pharmacy.
Oh, that
And
was
I
all.
was like, that's what I needed. That I was thinking about joining. Pending meetings. You know,
Well, where's John? John.
Yes.
Well, we also have at least 2 meetings in Spanish a year.
Yeah.
Right, John? Dos veces al año una reunión pasa en español, ¿no? And so we're gonna have one.
But are you the one running the Spanish?
Yeah.
speaking-
No, he does. Right,
Okay.
because because he's really Mexicano, no?
Give him
John?
his pen.
No, so I wanted to let you know. I know you work with somebody who does Ayurveda. Because I study Ayurveda and so.
Oh, who's that?
No,
Dr.
I-
Jasmine?
Yeah. Uh-huh.
Oh, Yosef. He's gonna come talk in a month or two.
All right. Okay.
Are you an Ayurvedic practitioner? You?
Yeah, I study Ayurveda in science.
No, I very much want to talk more about that because we can talk in a different way about nutrition.
Yeah.
Yeah.
And also, I'm a nutritionist.
Uh-huh.
I
My name.
see patients in online. That's where I work.
What was your name again?
Tony, any point about tonight?
Yes.
Called Blood Moon. You Google it.
Right.
It's kind
Oh,
of a
Ruben
murder
Day.
mystery. Big guy.
It's,
Usually takes those
Oh, I'm gonna ask him one more question.
pretty risky. But it's,
Oh, it's REU, so it's Reuven. Reuven. This is Reuven.
John.
Thank you.
It's not.
Yeah, we're slowly growing, and